Okay, so my name is Jenny Wilson O'Reilly. I'm a clinical psychologist. I work at Beaumont Hospital. And despite my accent, I've actually been there a really long time. I've been at Beaumont for about 19 years. I work in liaison work, so that means I see people from around the hospital for lots of different reasons. Sometimes to do with chronic diseases, sometimes to do with other stuff, or just pure distress. So I've been there 19 years, expect to be there another 19, and then I expect to check in as an inpatient and stay for a bit longer. So I'm talking to you today a little bit about self-management. And one of the quotes that Rashan was talking about in his beautiful talk, very compassionate and erudite talk there a few moments ago, was this quotation from one of his participants that said, people expect nothing of me. And that really hit me because I guess talking about self-management, talking about the type of self-management that we do at Beaumont and that is actually happening now around the country, there's a huge expectation on service users. There's a real demand to turn up, and there's a real demand to contribute. So it's almost the polar opposite of the idea of not expecting anything. I work a lot with peer leaders on our program, and I expect a lot of them, so much so that sometimes they reflect that back to me. But that idea of engagement and who's in charge and how can we make what we do make sense to the people we're doing it with. And the only way to do that is to put people who know what it's like at the center. So that's kind of the theme of my talk. And people made reference in their talks, Alan and Rashan earlier, to like yesterday. And what they were talking about was yesterday there was a day for healthcare professionals. And I gave a kind of a version of that talk and asked them for kind of input and their thoughts, whatever. And what I didn't say to them was that I was going to report back to you guys today on what they had to say. So I hope you can bear with me on that. And I started yesterday with some difficult subjects. For example, I started with death, okay? And I showed them this slide yesterday about world mortality rates, okay? That despite all the work all of us do to manage our health and to help other people manage their health, we're all going in the same direction, okay? And I apologize because this research was from '97, so it's kind of old, but I think that the stats are holding up, okay? And I also made the point to them when I was talking about death. I talked about illness, and I talked about that kind of arbitrary line between healthcare professionals and service users. I was at a meeting on Thursday at Beaumont, and we were talking about wellness initiatives. And I shouldn't make that face when I do that. We were talking about wellness, and they were saying, okay, so, you know, do you want to be on the committee for wellness for staff, or do you want to be part of the working group on wellness for our patients and service users? And I was like, what is going on here, folks? Like, we're all the same humans. I've got a freaking appointment with cardiology next Friday. Like, which am I? And it just to kind of highlight for them and for us that none of us gets out of this alive, that we're all managing one thing or another, that 50% of Americans, notice the accent, 50% of Americans over the age of 40 have at least one chronic health condition. So that idea of working with these bodies that continuously let us down is at the heart of self-management. So I started yesterday with death, and then I swiftly moved to misery because I talked to them about some research that was published at the end of 2016, and it was published in the Journal of Abnormal Psychology, okay, which is a good journal in psychology, and it had to do with enduring mental health. Okay, and it came from a research group from Dunedin in New Zealand. And there's lots of different ways to do research, but the real gold standard of epidemiological research or prevalence research, so who gets what when research, is epidemiological, which means it's everybody, okay? So they're not looking at people who turn up at clinics, they're looking at the entire population. And longitudinal, which means that they're looking at people over long periods of time. So the Dunedin cohort is this really famous cohort of babies that they started with, and they have tracked. They took all the babies. I said that yesterday, I'm like, they didn't take them anywhere. They invited all the babies into the research, and they started with health, and they started tracking them in infancy. They even actually started in pregnancy. And then at age 11, they started looking at mental health. Sorry, that just flicked off. At age 11, they started looking at mental health. And every few years, they go back to those exact same people, and they assess them for a million health things, including mental health. And so the paper that I'm referencing, they had just had their 37th birthday. And so they had just been assessed at that point. So when we're looking at mental health, we're looking at between age 11 and age 37. And they had been assessed at 8 points during that period of time. Okay? And the people who were assessing them were trained mental health professionals. So they weren't graduate students, they weren't volunteers. They were, highly trained, they were trained mental health professionals. And they were using kind of gold standard tools to assess them. So we use, in our work, something called the Diagnostic and Statistic Manual of Mental Disorders, okay? And it has a few iterations, and so that's what they used. And they interviewed these people and assessed them and published the results. So I asked these health professionals yesterday, what percentage of people do you think met the criteria at one of those 8 points between age 11 and age 37 for a diagnosable mental health disorder? So we're not talking about stress, we're not talking about kind of low mood, we're not talking about bereavement, we're not talking about those kind of normative difficulties that people have. We're talking about something that could have been diagnosed had they been in a clinic, okay? So I asked these healthcare professionals, and you can imagine there was a wide range. Some people said, nobody said as low as 10%, some people said 20%, and I think it might have gone up to 75%, I think was the highest, okay? So what do you guys think? I'll tell you what they said in a minute, but what percentage do you guys think of the general population between the ages of 11 and 37 could at one time point be diagnosed with an actual mental disorder? What do you think? 100%, says one person in the front row. 50? 80? Okay. 100% again. These are the realists over here. The optimists are going with 50%. Okay, so the realists have it. It was actually 83%. Okay? So at some time point in those eight sessions that they met, and so the researchers said, I wonder what's going on with that other 17%. Were they, was there something special about them, or did they just not realize how miserable they are? So they actually sent people out. They got their doctors in. They got a significant other in. I was just thinking, what would my husband say? But we won't go there. And they really examined them. And actually, even with all that collateral information, they were good. That 17% actually were pretty good. Okay? And then they looked at what was special about them. So what do you think it was? What kept that 17% happier than the rest of us? Resilience. And what do you mean by resilience? Okay, so glass half full, kind of optimists, and they use their tools. Yeah, okay. What else? Any other ideas? Community, family support. Yeah, no, these exercise, Yeah, no, it wasn't that. Wouldn't that be great if jog and then I'd be in that 17? No, it wasn't. It was the stuff, healthcare professionals would think, okay, it's family supports, it's money, it's, opportunity, whatever. It's actually this. It's like constitutional happy. They're just jollier than the rest of us for their whole lives. And then when you track them, they actually do better too. So not only are they happier than us, but they get more money, they have more friends, they do more fun stuff. Okay? That's kind of slightly annoying, okay? But the reason why I talk about, first of all, death, and secondly, misery, is because they can be invisible to us when on a day-to-day basis. We don't think about it, and yet it's happening. We don't talk about it often, and yet it's happening. And when we're on our own in misery, very often we have the experience we are on our own in misery. Or like I often have people I'm working with say to me, I'm in the clinic and I'm looking around and everybody else seems okay. And I'm not okay. And so I kind of make a point of talking about this research at the very beginning of most of my talks because of the idea of stigma. And you heard about it in the other talks this morning. It's like, can I be how I actually am? And can we, those of you who might be in the 17%, can you wake up to the idea that actually that's quite abnormal, that you're so happy all the time, which is how it got published in the Journal of Abnormal Psychology? And those of us who are in the 83% to acknowledge that actually misery is part of our experience, and it's a normal experience, even when it's quite pronounced. Okay, so I know it's kind of a tough place to start a talk like this, but I did, and you guys were way closer than the healthcare professionals. I think, yeah, they maxed out at 75%. So this is that paper, just to show you that I wasn't lying, okay? And this is a little chart from that paper. It's useless up here, but I just want to show you this bit. This is that Dunedin study, and they tracked it, and here you are, that 83% of people diagnosed with a mental health disorder. I'm just having a little think about this now. Okay, so another thing that, I'm going to go backwards here, that I talked about with, hold on, I just want to make sure I'm not going to miss this later, yeah. Okay, that I talked about with healthcare professionals yesterday was, talking about self-management. What are the skills, what are the tasks, what are the things that people who experience MS, people who are living with MS, what have they had to learn since their diagnosis? Okay, in terms of like managing everything. And so they made a list. I've got it here. That was close. And here's the things, I'll read it out, that they said that you guys have had to learn in managing a chronic illness. People have had to learn to educate themselves. They've had to learn to acknowledge that they have a diagnosis. They've had to learn how to manage their physical symptoms. They've had to change how they do things. They've had to overcome prejudice. They've had to adjust their roles. They've had to manage medication. They've had to tell other people and figure out how and when to tell other people, so just what Roshan was talking about. They have to deal with the perceptions of other people. They have to join some organization or activity around the condition that they have. They've had to grieve. So I had to write grief up here because I couldn't remember in the moment how to write grieve. So they've had to grieve. They've had to manage their fear of the future. And they've had to learn to balance acceptance and optimism. So how does that feel? Does that feel pretty good? Okay. So can I just ask, what's missing on this list? I heard a voice, but I didn't hear what it said. Can somebody... Thank you. Ask for help. What else? What else? Oh, yeah. So you've had to learn how to ask for help, and then you've had to learn how to accept help? Yeah, what else?
Be kind to yourself.
Okay, be kind to yourself. What else? Talk to somebody. Learn to say no. Okay, accept yourself. That's okay. That's accept help. Accept yourself is a different thing. Yeah. I'm just going to put wake-up call. And I'm going to put wake-up call regarding other people. Is that fair enough? Okay.
And to listen to your body.
Yep, to listen to your body. Put things in perspective. Yeah. Resilience.
Finally accepting that nothing wrong with you, or there is something wrong, so he's okay.
So can I put communicating with family? Did you say family accepting? What? Say it again.
You know, with my own family, they say, he's okay, but no,
So can I say managing family? Is that something that you've had to learn how to do? Telling family. Okay. Thank you. So telling family. And I like that, whether they accept it or not. Telling family again and again. Yeah. Yeah. So can I put managing friendship or accepting loss in friendship? Both of those? Yeah. And one of the things that's not coming up here, hold on. One of the things that's not coming up here, and it didn't come up with them either, was all the practical stuff. You know, it's like who to call, you know, which secretary is going to answer the phone, you know, which neurologist calls back, who accepts email, who doesn't accept email, where to park, you know, how to access parking, how to get refunded for things, you know, all of the millions of tasks that go around managing an illness. And it's almost like, I mean, I don't know if the healthcare professionals see it, right? But it's almost as if in this room, you guys have been living that for so long that it's like you don't even notice that there's skills that you've built. You know, but every time you pick up the phone and you're like, oh, I'm not going to call that person. I'm going to call this person because they'll answer and get back to me. That's a skill. Yeah. You shouldn't need that skill because we should all answer all your calls and get right back to you, but we all know that doesn't happen. So knowing who to call and how to do it and how to optimize the likelihood that you're going to get what you need, those are skill-based behavior. Yeah? Learned through experience. And that's what we're talking about. We're talking about all this stuff. We're talking about all the stuff they mentioned, and we're talking about all the stuff that you guys do, all that, all those tasks. Those are all self-management. It's like, how do I manage all of these parts of having a health condition? Okay. Yeah, so that's self-management. Those are, I mean, there's lots of other things. I could do this. That's like a million little pieces of information. But it all boils down to these three tasks. Managing your condition, managing your role, which is like all the other stuff that tells you who you are, whether that's work or family or relationships or chores, you know. And then finally, managing the emotional challenges of having a chronic condition. And that is just as important as the other two, but that's like the invisible skills, right? You guys are talking about invisible symptoms, but that's invisible skills, and they're very real. How do you manage the ups and downs, the constant adjustment, all the tasks, all the other, I have to be careful with my language because I'm being taped, all of these other things, and manage the normal misery of life. And no, you don't have a choice, right? But what you have a choice in is how you do it, right? So when we talk about self-management, we talk about kind of passive self-management or active self-management. That's the choice. It's not the choice about whether or not it's happening, but it's how you do it. And that's skill. And so sometimes people have this idea that either they're good at it or bad at it, and that's the way it is. But actually, all of those skills, just like all the skills we've already talked about, they develop. And they freaking need support in developing, which is where this idea comes in. We actually have to help people and ourselves to manage these three things. And we can't expect that people don't need help in developing these skills. Okay. So this is the reality, right? It's like we're with our healthcare professionals for this tiny little piece of the pie that is our lives. So I think Arshan talked about that 11-minute consultation, you know, or our inpatient stays or whatever it is, you know, this very small wedge. And then the rest of the time, the orange part, we're managing our condition. We're asking for help, we're accepting help, we're, you know, all of that, like all the tasks that we already talked about, all those skills that we need to develop and manage. And so when I talk about self-management, and now, I mean, there's a lot happening in Ireland around self-management. This is what they're talking about. It's like, how can we support people to manage their conditions? Not in the absence of the medical and support management that they're already getting, but in addition to. And what supports can we put in place to make that happen? And that's what I'm going to be talking about in terms of what's happening here in Ireland. And a lot of this is around, people talk about acceptance, and it's, many times before we've been diagnosed with something chronic, we've had other illnesses. And it's like you get an acute illness, you go to the doctor, you get your prescription, you get your arm set in a cast, you get whatever, blah, blah. You take care of that, it goes away, and you never, ever, ever have to think about it again. And that is often the model that we have in our heads if we've had a healthy childhood. That things are short-lived and we can stop thinking about them. And acceptance, part of it is this. It's like the challenge of having an ongoing health condition actually requires different kinds of skills than the challenge of having an acute illness. And that ties into the way we cope with things and that idea of resilience and what skills we're using, which I'm going to talk about in a minute. Like, how can we tolerate the fact that we have to think about having a chronic condition in order to take care of ourselves? And you guys already mentioned much of this, you know, that it's not just about managing symptoms, it's also about all these other pieces. Learning new behaviors, managing relationships with healthcare providers. That can be very difficult. And when you know that healthcare provider is going to be there for the next 19 years or whatever, that relationship that you have with them is actually really important. Managing the emotional and social consequences, that idea of protecting yourself and other people. You know that grief, loss, sometimes we don't like to ask for help because we don't like the other person feeling sadness or feeling frustration, and we're trying to protect them from that. And very often I'm in the hospital and I'm talking to that other person, that significant other, and they're saying, I don't know what's going on. She won't tell me, he won't tell me. And both people are trying to protect each other. maintaining relationships with family and friends despite loss, despite the idea of activity-based things that we might not be able to engage in anymore. And how do we maintain friendships when, you know, we're not maybe able to participate in the same way, when people can be worried about offending us, you know, trying to protect us, and we're trying to protect them, and friendship can be vulnerable in those circumstances. And that last one up there, I think that's the most important one, the constant adjustment. Adjusting to change over and over again, adjusting to new medications, new side effects, new symptoms, changes in our caregivers, changes in our, you know, family life, all of these, and always having to adjust. So, this is ridiculous, this slide, but I'm just going to use it to show one thing. So here's a personal model. This example is diabetes, but you can kind of put any chronic condition in there, right? But it's your personal model. It's the way you think about your condition, okay? And then I pressed the wrong one. Okay. And then you see this, strategies to manage the illness. So that's managing symptoms. So you engage in managing symptoms. Then you take, you know, that has an impact on your health. And then that goes over here into how you think it's working, right? So that's your appraisal. And that feeds back into your personal model, okay? So say in this example with diabetes, you know, you manage your sugar, you check your sugars, you take your insulin, you do all that, so you watch your carbs, whatever. You feel your health is okay, it goes into your appraisal, and you're like, yep, that's the way to manage diabetes, okay? And if that were the only part of this model, it would be super, super straightforward. But you see the second half? Oh, there we go. There's emotion, okay? And very often when people are trying to manage emotion in the face of illness, we get very different outcomes, because we all know that when we experience fear, what's the most common reaction to fear? What do you do when you're afraid of something? You avoid it, okay? You try to get far away from it. You know that fight or flight response? I mean, when it's something like a chronic illness, there's not a lot of fight going on, you know? And the idea of thinking about it becomes fearful because of uncertainty. We had a big talk earlier, and I think they're repeating it today, about uncertainty and how difficult uncertainty is, and fear-inducing. And we're humans. We're made to be a little bit nervous about uncertainty because we're always trying to protect our ability to reproduce, right? That's the whole biological imperative. So uncertainty creates fear, and fear creates avoidance. So it's really common to not want to think about whatever it is that you have to do to manage your illness. And so people talk about adherence, you know, to medication. And again, when people are not adhering to medication, they feel like they're the only one in the clinic who isn't taking their medication as prescribed. Anybody like to guess how many people don't take their medication as prescribed? What percentage do you think? It's not 100. Don't guess 100. A third of people, 75% of people?
68.
Very specific, 68. Okay, it's not 68, but I'm impressed with the number. 50%, okay? 50% of people do not take their medication as prescribed. Okay? If you're not taking your medication as prescribed, you're not by yourself. And healthcare professionals don't like to mention that because there's kind of a feeling like if we admit it, more people are going to stop taking their medication as prescribed. But actually, that doesn't have an impact on health behavior. Okay? What does have an impact on health behavior is acknowledgement and kindness, and decreasing the amount of stigma and shame. Okay? Which is why I always mention it, because you know what? If you're feeling embarrassed or whatever about not taking your medication, once you know that that's normal, it can sometimes loosen things up a little bit. Because shame creates fear. And what does fear create? Avoidance. So that's why I put this up here, even though health psychologists, I'm not a health psychologists hate this because they've moved on and they've got like super fancy models or whatever. But this is actually really helpful for me to think about, and hopefully for you guys to think about, that there is the illness part, but there's that emotion part. And if we're not taking care of both of those things, we can run into a little bit of difficulty. Oh, here we go. So, so another thing that happens to me a lot in the hospital is this idea of coping. People talk about coping. They're not coping. Other people aren't coping. Somebody's not coping the way that they want them to cope. You know, they're not talking to me, and so they're not coping, or they're very upset, so they're not coping. And I get it from healthcare professionals. I get it from service users in the hospital. You know, this whole idea of coping. And there's a huge amount of research in psychology around the concept of coping. People define it in different ways, et cetera, et cetera, et cetera. And essentially it boils down, in some research, to these three ideas of coping. There's a kind of a little debate. There's a fourth one called meaning making, okay, which is where people think about the difficulty that they're in a broader context of their lives. And it's like, what is this teaching me, nearly? Which is kind of a tricky thing to talk about, because it's like, oh, thank goodness you learned that lesson by getting this terrible disease. Like, that's not a great opening, okay? But yet, there is a very powerful thing around making meaning and learning. But anyway, these are the other three that are more commonly talked about in the coping literature. This idea, and this is most people's favorite, is problem-focused coping, where it's like, I got this problem, I gotta solve it, here's all the different ways I'm gonna do it, then I solve the problem, and then the problem goes away, which is super, super handy, and it got us here today, all that problem solving, negotiating, everything, whatever. But sometimes, obviously, we have problems that cannot be solved. And so there's another coping strategy that we use called emotion-focused coping. And that's the stuff that we do to support our emotional health. So that's the talking to people, that's all the kind of meditation-based strategies. Exercise is a good emotion-focused coping strategy as well, because we know exercise lifts mood, in addition to maybe being problem-focused and helping with our muscles. Social support, emotion-focused coping, joining programs, joining groups, emotion-focused coping, okay? But we can't forget about this guy over here, avoidance, which up until now in my talk I've been a little bit discourteous to. Avoidance can actually be a really handy coping strategy if you haven't tried it. No, I'm just kidding. But sometimes not thinking about things can actually really help with our mood. Sometimes avoiding conflict, avoiding discomfort can help with mood. I know I'm preaching to the converted here. We've all probably used avoidance. So the idea is not to use it all the time for every problem, but to acknowledge it as a strategy in our coping strategy in general. And then the other thing I want to say is this one here. Maybe because I'm a person with strong emotions, I like to emphasize this. But grief, sadness, anger, frustration, those are emotions. Joy, okay, these are emotions. Humans have emotions. If you are experiencing a very strong emotion, that does not mean that you are not, in that exact same moment, coping. So sometimes people have an expectation that they're meant to be, when they're coping really well with things, kind of like Zen. Okay? That is not the case. Zen sometimes doesn't get you where you need to be. Anger sometimes can get you where you need to be. And just because you're angry doesn't mean you're not coping. So just that, coming back to that idea of kindness and listening to your own body and accepting yourself, just be very careful about how you treat your own emotions. Sadness is another one. You can be extremely sad and still coping. Okay. And then, a little squashed brain there. So psychologists talk a lot about stress, and there's a long history, all the way back from the idea of a stressor and a stress response, many, many, many years ago. And a lot of the literature has been around managing or avoiding stress, changing our lifestyles so that we don't encounter stress as often, or we're we get to that Zen place where stress doesn't affect us, this kind of idea. There's some really interesting research coming out in the last 10 years around stress, around the acute stress reaction, and also around longer-term stress reactions, that demonstrates there's actually a lot of benefit to having a stressful life. It's not a popular message, okay? It really isn't, and I understand that. But there's a researcher at Stanford University named Kelly McGonigal. I kind of have a crush on her. And she has published a lot. She has some really interesting stuff on YouTube, Kelly McGonigal. And she talks about this research in a very accessible way. And she talks about large-scale international studies that looked at how stressful people's lives are and looked at health outcomes, looked at millions of other things, okay? And how how stressful people experienced their lives actually correlated with pretty good health outcomes and with a real sense of meaning. That people who have stressful lives also have really meaningful lives. And one of the ways that she defines the stress reaction is what happens to you when something you care about is on the line. And I find that a very affirming way of looking at stress. Because if we didn't care, we wouldn't be stressed. And part of being human is caring about other people, caring about what we do, finding meaning in what we're doing. And it's that meaning and the frustration that comes with not meeting those things, or not managing those things, or not getting to where you want to be, that creates stress. So when you think about your stress reaction, when you think about your experience with stress, just factor that in. Obviously, the things around managing our physical arousal, things like relaxation, things like breathing techniques, all of those things are extremely helpful. But not thinking about it in terms of avoiding stress. Thinking about it in terms of building resilience. How can I prepare myself to go into the next fight, rather than how can I avoid being stressed out again? Does that make sense to people? Yeah. It's really good. It's really good to look up some of that researcher. She did a TED Talk that's phenomenal around it, Kelly McGonigal. But thinking about stress as something we're working with, not something that we're trying to avoid or get rid of, same thing. Okay, so then I asked the healthcare professionals, all right, so we've got all these expectations around what the people who are coming to meet with us are doing. You know, we have they've got to take care of their health in all these different ways. We see them for this little pie, a little slice of the pie, and then we send them off to do all the rest of the stuff. How are we helping them to support their own self-management? Okay? So that's a shorter list than their other list. So this is what the healthcare professionals said that we're doing to help people in self-management. And they talked about goal setting, helping people to identify where they want to be and how to get there. They talked about identifying priorities for treatment and for management. They talked about education, helping people with kind of where the bigger picture of where they want to be, and then the starting point, like what is the next step toward that bigger goal. And they talked about signposting local supports, so identifying other services that can help people in self-managing. And so I was looking at all those skills that we're demanding people do to manage their health. And then I was looking at this list, and I was thinking, we actually have to do a little bit more to help people manage their own conditions and increase the likelihood of success in self-management. And that's where this next part comes in. It's like, what have we done? I'm, like I said, at Beaumont Hospital, but I work in a bigger consortium. And what is being done nationwide to help people develop and improve their skills for self-management, for all those tasks that we already identified? So what we do at Beaumont, we call it Better Health, Better Living, okay? But do you see that CDSMP that's next to that? That is an acronym that stands for the Chronic Disease Self-Management Program. And that is a 6-week program that people attend for 2.5 hours once a week. Okay? It's structured, it came from Stanford University, not Kelly McGonigal, okay? A different person at Stanford University that I don't have a crush on. And it's for anybody with any ongoing medical condition. So we run very generic programs for, people with MS come, people with inflammatory bowel disease come, people with epilepsy come, people with Huntington's disease come. We get a real range of conditions, and we work together on self-management. But you see the second point there, or maybe it's the third point, it has 2 trained facilitators. But one of those trained facilitators must be a person who is managing an ongoing health condition. Okay? They did some really great work when they were rolling this out 30 years ago. This has been going on for 30 years internationally, about what people learn and how they learn. And they tried this program with 2 health professionals, and they tried it with 2 peer leaders, people with health conditions that had been trained. And they looked at how people fared, okay, that had attended the programs. And the people who had attended the programs with healthcare professionals, 2 healthcare professionals, they came out knowing more about self-management. So they had a much, they just knew more about it. But the people who attended the programs with 2 peer leaders as the facilitators finished the program doing a lot more, actively self-managing their conditions, much more involved and engaged in the material. And that has there's lots of reasons for that from psychology. We can talk about, and I have a slide on it, we can talk about modeling, we can talk about persuasion, we can talk about social support, these ideas that it's easier to learn, from somebody who knows what you're going through, that you can see knows what you're going through, than from somebody who doesn't. And so there's lots of psychological frameworks we can put around it. But as somebody who's experienced these groups and has worked with peer leaders in my program, I could say that there's a deeper core to that, where they know what it's like. And that is a very different experience than me standing up there talking. And that's where I start making my demands, where I'm like, I see this happening, and I know that peer leaders are way better at this than healthcare professionals. I train them all together. We've run it out. We've been doing it for 6 years. I'm much more likely to get a healthcare professional call in sick, ironically, than my peer leaders. Way more, like 90% more. And it's because they know what they're talking about. They know what it's like. So anyway, it's evidence-based, so there's been a huge amount of research done internationally, like I said, over the 30 years. And it's endorsed by the HSE, I'll talk about that in a second, by the Center for Disease Control in the States, by the National Council on Aging. The NHS has the Expert Patient Program, which is the exact same program. Other places where you all might have encountered it, Arthritis Ireland run the exact same program that we run. They call it Living Well with Arthritis, but now they've changed the name, and it's Living Well with Arthritis and Other Conditions. They run the program. The Irish Kidney Association run the program. The Irish Society for Colitis and Crohn's Disease run the program. The MS Society in some places run the program. In the Southeast, in Dublin North, they run the program. They also partner with, the MS Society partners with Mayo and Longford and Roscommon in running the program around that area. So you all might be familiar with this program already. And there's a lot, the reason I have the word patient up there for this is because of all the talk and writing on patient engagement in the hospitals. And so people are constantly saying, how can we get patients more engaged, so whatever. And we did a little bit of research around this program, and this is a quote from one of our peer leaders, and he's like, I walk into this hospital, I'm not just a disease with a pair of legs, I'm actually contributing, I'm making a difference. It has some meaning, what I've been through, because I can help other people. I was quite worried. We did this research because I was worried about the demands I was making, and I was thinking, is this too much to expect? And we interviewed 15 people who'd been through it. I didn't interview them because they all, would have told me what I wanted to hear. We had independent researchers do that, and it was overwhelmingly positive. People felt very connected to the program. So this is what I was talking about before, that, the social learning theory, how people learn, and it uses these techniques of modeling, rehearsal, allowing people to actually try it in the 6 weeks and fail, and then figure out why they failed and strategize around it, giving people actual information that's trusted, and providing social support as well. And really, like I said, it's skills-based. We look at all of these different things in lots of different ways as we go through. It kind of covers a lot of what we talked about in terms of the skills that people need. And my favorite one is the one at the bottom, working with healthcare professionals. That's actually a skill. And so it's like, how can you, manage the difficult interaction with the neurologist? How can you, manage the difficult, the parking? How can you manage the paperwork? How can you manage without having a freaking electronic record of everything and people not reading your charts and all that stuff that goes on? That's skill-based behavior. But also communication and medication and weight and pain and physical activity and problem solving. And there's a generic program, which is the one that we run, but there are also some very specific programs. There isn't a specific one for managing MS, but there is one for managing pain. There's one for managing survivorship in cancer. And again, that piece around uncertainty. There's one for diabetes and HIV, and there's one for caregivers, and there's one place in Ireland that has started using the caregiver one as part of a research trial. And then there's one for workplace. So at Beaumont, we're trying that caregiver thing, we're trying the pain one, but we mostly run the generic. But what's happened now in I'll just show you. These are our partners. We work with Arthritis Ireland, with the ISCC, with St. Luke's, with MS Ireland, Dublin North, and the Irish Kidney Association, and the Mater Hospital as well, which I forgot to mention earlier. And we did some research, but it's not rocket science. It's been going on for 30 years. There's international research supporting this program, but we did it as well in partnership with our team. And you can see some of the people. Sean Kinsella is a part of Dublin North MS Society. And we found significance in total activity, in people feeling that self-efficacy, feeling like they actually have some control and way of managing what they're going through that's different from how they started. Quality of life, depression, and the depression and quality of life one was really interesting because that was our second paper, and it took out people who met criteria for depression, and it tracked them separate to everybody's mood. And what it showed was that post the 6-week program, everybody's mood was better, which is common because they were all hanging out together, and it was awesome. But then it looked at them again 6 months later, and those people who had kind of met the criteria had actually continued to improve in terms of their mood and quality of life. So that was very powerful for me because it was like they're using the skills. It's actually, it's continuing to support them even though we're not meeting on a weekly basis anymore. And then there were some people who took that program and did it specifically with people living with MS, and they also demonstrated improved physical status, improved self-efficacy, improvement in mood, and maintaining it at 12 months, which is good news. So here's where this gets a little political, okay? So we know that this particular program is being supported in the HSC, that it was part of their strategy for living well with a chronic condition. And this was demonstrated, or this was published a couple years ago. And as part of their strategy, and you guys might be familiar with this, each area got somebody called a self-management support coordinator. And those people spent the first year or whatever of their post mapping. So they looked at what was already going on in terms of self-management support, all the different programs out there, okay? And now they're trying to support these programs. So something really exciting that's happened only in the last month or so is that 6 out of the 9 areas have gotten very specific funding for the self-management program that I'm talking about. And that means that they have about a year to demonstrate effectiveness in order to continue that funding. So this is a Sláinte Care initiative, and it's super exciting because it hasn't been centrally funded before. So that's where this idea of using the expertise of our peers, of people who actually have chronic conditions, becomes really central to the success of the program. So you're going to be hearing, if you don't hear it through the MS Society, you'll probably be hearing about it from lots of other forums of people asking people with long-term health conditions, can they help? Can they become trained? Can they give back some of the skills that they've learned? Can they get involved in self-management support? So don't be surprised if that happens to you. And it's we had a national meeting back in May, and people who are running this around the country came together, and we kind of agreed that partly it's to do with healthcare, and partly it's to do with almost like a social movement, to put people at the center of their own care, and to say, actually, we know this much, but you guys know way more about how to manage this, and how can we use that expertise, and how can we get people together to help each other. And it kind of fits in with when Ava was talking about the first talk this morning, and she talked about that survey that they sent out, and they asked people what did they want. And people said things like they want more activities, they want more advocacy, they want more on symptom management, they want more on peer support. I mean, these are the kinds of things that's already out there in terms of need. So, oh yeah, so here you go. So that's what's next. It's like, ask for self-management support. These coordinators are in every single health area, and the only way that they know there's a demand is if people ask for it. Volunteer for training as a peer leader if you're approached. And also MS Ireland, like I said, they're liaising in pockets with this program and with other self-management supports. And so being involved in the society, in the MS Ireland Society, is actually really valuable for them because they can ask you, what do you want, what do you need, what can we provide in terms of training, and then in terms of actual services as well. And this is one of our participants who talked about anything is possible when you map a plan to achieve your goals. I love doing the action plan every week. Even when I was feeling miserable and in pain, I still found something to plan and some sense of accomplishment. The journey is more important than the destination. And for me, you know, things have been moving forward, and like this, we got this exciting funding and all this stuff, and that's maybe a destination, right? But the actual learning for me has been in working with my peer leaders and realizing the depth of their expertise, that idea of not just a disease with a pair of legs, that people have chronic conditions, but then they have this huge amount of skills, of course, right? Of course. And that they're so willing to give back and to advocate. And that's been a really important part of the journey for me, is seeing the strength of that and how that has an impact on other people attending the services. So I think that's, that's almost my last slide. This is a guy self-managing his laundry. He's like, what is this? I'm very happy, though, I'm going to finish there, but I'm very happy to take questions if people are interested. I'm conscious you guys have been stuck in here for a few hours now. Thank you. Oh, you're very kind.
Yeah, it's just the self-management courses and whatnot.
Yeah.
I'm conscious of being from Donegal. We have absolutely valuable facilities there. Are there anyone from Donegal on any of your self-management courses?
Donegal is actually a shining light. They have an incredible service there.
Where is that?
It is, well, I was up in Letterkenny doing a training
Right.
there a couple of years ago, and there's a woman named Maeve McKeown. She used to be the self-management coordinator, now she's got a big, fancier job, but it's really easy. Her address is Maeve McKeown at hsc.ie.
Okay.
But they have incredible, they have so many groups run throughout Donegal.
And how would we get in touch with her? Through Letterkenny HSE or?
You could do that, yeah, you could do that. You could just email her.
Maeve McKeown.
Maeve McKeown, yeah. But actually, they started very early, and they've got a real reach across that whole area. Mm-hmm. And they were really hard to train. No, I'm just kidding. They were awesome. There was a lot of pushback. Jeepers creepers.
Also be a part of helping a person to look after themselves, if you know what I mean. Letting people be aware of your difficulties, not you in particular, but illnesses that the difficulties they have.
Yes. Yeah. I mean, I think what you're asking is, does it make it more visible what actually people are going through? Is that what you're asking?
No, I think to get it into the schools,
Oh, yes.
you know, to make people aware of disability.
Yes. Just generally more education. Yeah,
Yeah.
absolutely. I think you're dead right. And also how common it is. You know, that there's not groups of pockets. You know, it's like people live with chronic illness. And a lot of it is invisible. I mean, we've been hearing about the MS, the invisibility of MS. But because of my work, because I work in a liaison service, you know, I hear that invisibility with epilepsy. You know, people have no idea when they're going to have another seizure. And they look just fine. Or people with inflammatory bowel disease. You know, they look great because they're mostly thin. You know, they look they look super healthy. And they can be extremely unwell. So, yes, certainly for disease-specific groups, but in general, I think it behooves us to educate everybody that people are living with a lot of difficulty. You know, like I said about death and misery, right? Also illness. Yeah. Thank you.
Yeah.
There's a finger up there. Yep. Oh, now a whole arm and a finger. Yep.
I just want to say that I actually did that course, the Living Well with Long-Term Illness, and myself and my husband both did it. I actually have inflammatory arthritis, myself and my husband has MS.
Did you do it with Arthritis Ireland?
With Arthritis Ireland, yeah. We just did it there back in May.
Wonderful.
So it's actually, I just want to say it's actually a very good course. So it's the two ladies that ran the course, they both had illnesses themselves. One had arthritis and one had fibromyalgia.
Okay. And
So
what was good about the course? Do you mind saying?
I just felt like everyone kind of encouraged each other, you know, and the action plans were a great thing because it actually took me 3 weeks to actually complete an action plan. But I actually did the same action plan for 3 weeks in a row because I couldn't complete it the first 2 weeks. You know, it was my own fault because my own self-management wasn't great. So, but by the third week, I actually managed to complete it. You know, so it's, as you go on, you kind of learn how to manage things. And, you know, and I've been kind of continuing that over the summer as well. And, you know, I've started doing a few more things for myself and thinking about things a bit more, you know, just thinking of yourself a bit more. And this thing of learning to say no.
Oh, yeah.
Talk about that earlier in another talk. Learning to say no and learning that you need time for yourself and that type of thing. I just thought it was a brilliant course, just to kind of remind you of things.
Yes.
Yeah.
Things you already know, but
Yes,
like you
just
put
to-
into practice.
Yeah,
Yes.
exactly.
And you get the
So-
support for it. Thank you
Yeah.
so much for
No.
piping up back there. I appreciate that. Was there another? I thought I saw another little thing happen. Oh yeah, there we go. Green shirt right here.
Does it depend on where you live, whether you can do this course or not?
He just asked, does it depend on where you live, whether you can do this course or not?
For example, I live in Mayo, and
Mayo's got a course. Yeah, you thought you'd get out of it, but no.
haven't heard about it yet.
Yeah, no, there's actually a very active team in Mayo, Roscommon, Longford, all that whole area is super well covered. Kathy McSherry at hsc.ie, she's kind of the queen of that area or whatever. She knows all about it. You could contact her. Or actually their website is, or their email address is selfcaretowellness at hsc.ie, I think. So they definitely do courses there. Now, one of the problems that we have, and we're working on our branding, is that many of these courses have different names. Like we call it Better Health, Better Living, Living Well with a Chronic Condition in Arthritis Ireland, Self-Care to Wellness in Mayo. Like they have different names, but they're the same course. So that's something that we're working on, is the branding of that, so people know it's the same thing. But Kathy McSherry at hsc.ie, she will point you in the right direction. And she's awesome.
Anybody in the Cavan locality?
Yep, Cavan and Monaghan are covered by the same crowd as that. I think they're covered by the same crowd as Donegal, even though that doesn't make sense. I know that doesn't make sense, but I think they are covered in the same area. So Maeve McKeown, that same person that I spoke about already, she would know. But there's definitely reach into Cavan Monaghan.
Right, Maeve McKeown.
Maeve McKeown at hsc.ie. She's going to love me
Okay,
after this
thank
talk.
you.
Yeah. Oh, and it's going to be online. Perfect. County Louth is, a bunch of people have been trained in County Louth, but I don't know if they're actually running the program. So whereabouts exactly do you live?
Well, we're the dog say.
Dundalk. So we have people who attend Beaumont Hospital who come from Dundalk down, and they attend with us, but it's terrible because the commute is so horrific. But what I will say, and this is so great to have people asking these questions, is that now's the time to ask these questions because now the money has arrived. Okay? And so when they hear people saying, actually, we want that course, I mean, this is what's going to happen literally in the next 12 months. Now people have this Sláinte Care funding, which hopefully is not a secret anymore because it's on the way. Anyway, it's not now. Now they have that. They're going to have to develop the courses in all of these areas, and they're going to have to demonstrate efficacy. So now's the time to ask your self-management support coordinator, where's my course? Every area, and that's online. If you look up HSC self-management support coordinators, each one of them is listed for your area and their phone number. Yeah. Or email, maybe, if they're smart. Yeah. Okay.
Margaret, and she told me that you'd be a great teacher. And I said, well, thank you. I've just given up nursing, so I'd love to do it. And I did put my name down, to do it. And is there anybody in the Northeast branch?
That's a really good question. I don't know the answer to that, but you should ask that question
To Aoife.
because I'm just going to put my name back up here, right?
Yeah.
Because if people want to email, you can email me. I'm sorry about the length of my name,
yeah.
but it's that name at beaumont.ie because I can answer these questions about specifics. But you can ask that question, like, what is the MS Society doing in this area? Because we know that there's an SMS coordinator. We know that things should be happening. And how can we support that to happen? Yeah, just one sec. We've got a follow-up question here. Sorry.
Yeah, no, it's just that we get tea at the tea break, and it was cups. And everybody with MS, we all said, you should really give mugs with big handles.
Yeah.
And I'm up there the next week, or the next year, and they give you mugs all the time now.
Oh, excellent. That's fantastic. That's excellent. That's good self-management. Thank you. That's perfect example.
It's just more or less the same question. You don't know of any supports in the Kerry region, do you?
So one of the things that's happened is that the cancer people have gotten phenomenal funding, okay? And so they've trained a bunch of people in the cancer-specific chronic disease self-management. It's called Cancer Thrive and Survive, okay? And they're in Kerry, okay? But those leaders can also run the generic program, okay? So what we need to do is support them to develop that way. So there are people in Cork, and Cork University Hospital is pushing hard to get this program. They've got some people already trained. I know that Cork and Kerry aren't the same thing. I know that. But they're pushing hard, and they're liaising with, I think, some people from Kerry. But definitely in the next year, they're going to be looking for peer leaders to train, and they're also going to be developing these. I don't know exactly where the funding has happened. Thank goodness they didn't tell me that, because then I'd tell you and I'd be in even more trouble. But but it's a good question to ask, and I would presume that things will develop because they've got the cancer funding down there. You're welcome. Okay, I think there goes an alarm. I think we're right on time to finish. Oh, wait, one more from the green shirt guy.
That's my Mayo colours. How do you qualify to take part in that type of
To become a
program?
peer leader?
Yeah.
Yeah, you know, I take pretty much all comers. I mean, you know, it's people who are managing their condition who feel an urge to help out. There's a 4-day training, and you have to survive that training, and it's, you know, it's quite arduous, but also awesome. And so there's a 4-day training process to become a peer leader. So if you can get through that, you could probably run a course.
MS, for example.
Yeah.
How do you advise other people?
Yeah, well, I mean, that 4-day training is going to weed out the people who maybe have the capacity to do it. Okay, thank you so much for being such a, you know, interactive audience. I really appreciate that. And good luck with your self-management. Onward and upward.